Thank you for joining us today. I want to welcome everyone to the STS 2023 webinar series. Today's webinar is titled Asian Pacific Islander Identity, Representation, and Inclusion in Cardiothoracic Surgery. Please note, this webinar is being recorded and will be available next week on the STS website and STS YouTube channel. We invite you to become a member of STS if you're not already. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership. At this time, I am pleased to announce and introduce our STS moderators for this evening, Dr. Cherie Erkmen and Douglas Wood. Dr. Erkmen, welcome. Let me turn it over to you.
Thank you, and thank you for tuning in today. We have a unique program looking at Asian Pacific Islanders and cardiothoracic surgery. This webinar originated from the STS workforce of diversity, equity, and inclusion, and will explore Asian Pacific Islanders, a group that has been called a silent minority or a model minority. We'll look into the history of Asians in America, as well as explore some experiences of surgeons within our own community. My co-moderator is Dr. Doug Wood. He is professor and chair at the University of Washington, and he's served as president on almost every cardiothoracic surgery organization that I know of, but he's shown true leadership in advancing diversity in CT surgery for decades. And I didn't know how to say that without inferring that you were old, but truly a leader in the field. So I am delighted to have you with us. I would like to also introduce Michael Lesgart and Alex Nguyen. They are medical students at Temple University Hospital and also the Center for Asian Health. And they're both going to start with presentations and give us context of Asians and the history within the United States. So, Michael, please.
Great, thank you. So before we get into our expert panel discussion, it would be great to come to our discussion from an informed perspective, just so we get a bit of background. So Asian Americans and Pacific Islanders represent 24 million people in the United States, and about 60% are actually foreign-born. One of the challenges when discussing AAPIs is the broad definition given to AAPIs by the US Census Bureau, which includes Asian as having any origins in the original peoples of the Far East, Southeast Asia, or Indian subcontinent, and defines Native Hawaiian or Pacific Islanders as having origins in any of the original peoples of Hawaii, Guam, Samoa, or other Pacific Islands. So this broad definition really leads to over 22 distinct origin groups being labeled under AAPIs. Each of these groups has their own distinct culture, socioeconomic status, education level, and income levels, which make it challenging to apply broad definitions and terminologies when you have so many different groups. Asian Americans first immigrated to the United States towards the end of the 19th century, primarily to fulfill the growing demand for workers as America grew westward. As they began to immigrate, they faced several discriminatory legislations, such as the Chinese Exclusion Act of 1882, the Immigration Act of 1917, the National Origins Act of 1924, all of which sought to essentially eliminate immigration from Asia and further instill xenophobic attitudes in American culture. And of course, this is massively exemplified by the horrific Executive Order 9066, which forced the relocation of 120,000 Japanese Americans to internment camps for the duration of World War II, punishing everyday Americans simply for being from Japan. However, the Immigration and Nationality Act of 1965 really paved the way for more immigration from Asia, and led to the preferential admittance of highly educated immigrants. And that really leads to the current distribution of AAPIs as physicians. So today, AAPIs comprise 7% of the US population, but 20% of all physicians. However, even though they comprise 20% of all physicians, less than 10% of the leadership positions in academic medicine or professional medical organizations were held by AAPIs. So part of our goals today is to describe the AAPI's experience specifically in thoracic surgery, and also discuss the lived experience of Asians in the specialty and in medicine in general. So I'll pass it off to Alex.
You guys see my screen?
Yes.
All right. So thank you for that, Michael. I'll continue where we are. So like Michael was saying, Asian Americans account for nearly 5.7%. He had 7%. It's around this range, and right now are the fastest growing minority group. And we're expected to be the nation's largest immigrant group by 2055. So unfortunately, because of the COVID-19 pandemic, there are things that there's been a lot of Asian hate that has come about. We've seen the president. I remember sitting here in my room watching the news while I was trying to get into med school, and he said the word kung flu, and everybody in the crowd laughed. Personally, that really hurt me. So what does Asian hate look like and how much is happening? I'm referencing a lot of data collected by this organization called Stop AAPI Hate. They're really, really awesome. And so I highly recommend you checking them out. But basically, over the first 2 years of the Stop AAPI Hate Reporting Center from March 19th, 2020 to March 31st, 2022, individuals across the country have reported up to over 11,000 incidents, right? And this number is just the tip of the iceberg. And there was another survey conducted in partnership with this Edelman Data and Intelligence that found 1 in 5 Asian Americans and 1 in 5 Pacific Islanders experienced a hate incident in 2020 or 2021. I can also personally say that this number is an underrepresentation because I've experienced Asian hate incidents 5 or 6 times, most of them in the healthcare setting. I didn't report any of them. So what does this really look like? Where are these taking place, right? So of these hate incidents, 2 in 3 incidents involved harassment, such as verbal or written hate speech or inappropriate gestures, right? We have a quote over here in Marin County, this person saying, this quote, he was emptying this trash and a guy pulled his eyes back to resemble, smaller eyes and then bowed to him. Very offensive. We have another one here detailing where these take place. So 2 in 5 incidents took place in public spaces, such as a street, sidewalk, road, park, hiking trail, or beach. And here we have someone in New York saying that a man called me a chink several times on the corner of so-and-so and started spitting at this person and tried to fight their boyfriend. Where are these taking place? Nearly 1 in 10 incidents occurred on public transit. We have this huge story. This person in Washington, D.C. was accused of being a Chinese spy, was getting harassed. And so what's the impact? Why is this so important? Why did I even show all that data? There seems to be some people that believe that Asian hate is fake and that these are just lies construed by the media. And I understand, the media, sometimes can be untrustworthy. However, as scientists and doctors, we believe in evidence, and this is data that has been collected, and we should listen to it. That's responsible. So, what has this done to people that have experienced this Asian hate? It's led to a lot of increased fear. Only half, 49% of AAPIs felt safe going out. 2 in 3, 65% were worried about the safety of family members and elders. 32% of parents were concerned that their own kids would be a victim of this anti-Asian hate in school, unsupervised spaces. Among the people who experienced the hate incident, 95% of them viewed the US as more dangerous for them. And elders who experience Asian hate, 98% believe that the US has become more physically dangerous for Asian Americans. And what do we have as a result based off some of this data? 49% reported depression or anxiety, and almost 3/4, 72%, named discrimination against them as their greatest source of stress, even ahead of the COVID-19 disease. So having said that, I actually do want to leave this intro off with one thing. I presented to you the data, and maybe people say, oh, that'll never happen to me. This is just data, this is just statistics. I have been asked to leave clinic rooms because I look Chinese by patients. During rotations in more less populated areas with Asian people, I've been honked at and laughed at for how I look. I can say that as a someone who's finishing their M3 year, I had a lot of pressure to perform, and I certainly did not appreciate also experiencing Asian hate, nor did I appreciate people telling me that Asian hate was fake, because it was very evident, the experience that I was having was very hurtful. And, I listed off 49% of people become depressed or anxious, are scared of getting attacked more than a disease process. I fall into that. I certainly do get depressed at times or anxious when I walk into a clinic room and think, maybe this person's going to ask me to leave again. And then it asks, I think of another question. Am I going to get evaluated based off of how I respond to Asian hate? And I think this event is really unique because it kind of lays out we're talking about a underappreciated, underrecognized experience in Asians in cardiothoracic surgery. So thank you.
Thank you, Michael, and thank you, Alex, for sharing your experiences. It's really important to bring it home on statistics to real life. We have a poll. Are Asians a minority in cardiothoracic surgery? And we'll try to hold the poll to the end and discussion just to see what our group participating today feels. But go ahead and answer, and we will move on with Dr. Wood and introductions of our panelists.
Yes, please do complete the poll. We'll look at the results of that a little bit later in the webinar. I'd like to move now to a panel discussion and hear some of the experiences of panelists that we have, and we've accrued a panel that are highly talented individuals, but purposely also have a diversity of backgrounds and positions. They represent academic and community practice. They represent early career and late career. They represent our subspecialties of congenital, adult cardiac, and general thoracic, and they even represent an aspect of geographic diversity, at least to some degree, meaning East Coast, West Coast. I'm not sure we've got the adequate South and Midwest diversity, but just very briefly introducing Dr. Stanley Lau, who's the founder of Southern California Heart Centers, Dr. Rick Kim, who's the chief of congenital cardiothoracic surgery at Cedars-Sinai, Dr. Suyog Mokashi, who's an assistant professor of cardiac surgery at Temple and a director of their aortic surgery program, and Dr. Kathleen Berfield, who's an assistant professor and general thoracic surgeon, as well as program director at the University of Washington. So I have a few questions for our panelists, and Dr. Berfield, I'm going to start off with you. Maybe you can just tell us a little bit about your background and how being Asian has impacted your career.
Yeah, well, thank you for the opportunity, Dr. Erkmen and Dr. Wood. I think my background is maybe a little unique. I'm Korean born, but adopted when I was an infant to a white father and a Japanese Hawaiian mother. And I am fortunate that I grew up in the Pacific Northwest, where the majority of the a large fraction of the population is actually Asian, about 16%, which is unusual, I think, for many cities. And so I feel like as a child, I was relatively protected from things. I actually grew up on Bainbridge Island, and the Japanese internment was mentioned earlier, and the Japanese community on Bainbridge Island was the first to be interned or sent to internment camps in 1942. And so I grew up with a really strong influence in the BIJAC community, which I think is really shaped a lot of what kind of my my thoughts and thought processes in terms of just the kind of how profound racism can be and the impacts on large communities. I think that, as I think about, my background and what it's done for kind of my career and the impact it's had, I can think of a couple instances where, traditionally, I was brought up by, a Japanese mother who was very, I was taught to be deferential to my elders and my leaders, which I think is pretty common for many cultures. But I think, when I think about, feedback that I've gotten in training, I very distinctly remember at the end of my residency program, during a faculty review, kind of it being relayed to me afterwards, like, hey, Kathleen, there were actually some concerns about whether or not you would be prepared to, finish, because you were very deferential in the OR, and the thought process was that potentially, Doug's shaking his head like, I've never seen this before for me in the OR, but that I maybe wasn't as prepared. And I think that, the faculty said, stood up for me and said, actually, she's fine. What are you talking about? She totally takes control in the operating room. And I think some of that, there's an intersectionality with being female, and not necessarily being as direct and upfront. But I think that background for me has definitely played a role there. As I think about Alex's story, his experience with racism and Asian hate, I feel fortunate that I've personally in the hospital not experienced that. And as I reflected on the incidents that I've heard through the pandemic about other people's experiences, I felt that in part I was protected because of my name as well. Kathleen Berfield isn't a traditional Asian name, and so I really, I think that as I interact with patients, they haven't Googled me ahead of time, right? They're not necessarily expecting an Asian woman to walk in the room or an Asian woman to walk into the room. And I don't know if Dr. Erkmen has had a similar experience or kind of reflections on that, but I do think that it's shielded me in many ways. When I was growing up, my middle name is Sachiko, and I used to go by, my family and all of our family friends call me Sachi. And I quickly dropped that when I got into school because it was so terribly difficult for people to be able to spell that name or say that name. And, adopted Kathleen as my professional name and as my name going through. So, I think that it's something that it's kind of always there, but it's definitely had an impact.
Dr. Berfield, you brought up this point about your name not being Asian, so that I guess it gives you a camouflage, is maybe a way to think about it. And you just educated me about something that I hadn't thought about before. And you posed, whether Dr. Erkmen has had a similar experience. Dr. Erkmen, has your name gotten you indoors where then your face surprises someone?
Definitely. I have, I assumed my husband's last name, and my original name was Perungo. So people don't know what the origins of that are. It's Filipino. But I think more than the surprise of when I walk through the door, people will say, and sometimes it is in a very kind and welcoming way, where are you from? And sometimes it's a little bit more suspicious, like, where are you from? And it takes a lot of different forms, because it kind of suggests, if I say, well, I'm from Colorado, then they say, where are you really from? That if they're not satisfied with Colorado, then perhaps they're just interested in my origins, and that is welcomed. But sometimes it's more suspicious, like, well, I really want to know who I'm dealing with and where your family's from. And I have had to redirect people and say, well, we're not talking about me today, we're talking about you. So I've experienced it, but I think a lot of times I have to take a step back and say they're not intending to be offensive or intending to be suspicious. I think there are definitely times when people are interested in who their doctor is. And I think one of the things that makes a difference is that I am their surgeon, where Alex is now a medical student on the service, that I think it's easier to exert some hostility against somebody who doesn't have the power to help them or take care of them in the way that the surgeon does.
Yeah, Dr. Erkmen, I have two questions about the where are you from? And maybe I'll direct it to Dr. Kim, at least at the beginning. I guess that's probably happened to you as well. How does it land on you when you hear where are you from? And have you developed a strategy for navigating it that you would advise some of the younger trainees, ways that they could be graceful, but also not lose any of their power in the process?
It's so interesting hearing some of these stories, because I've experienced all of these things myself, and as a kind of member of the model minority, of course, you try to do your best to sweep them under the table and kind of quickly move on to something that is less triggering or less offensive. I think what Dr. Erkmen said about power positions in the hospital are also very, very apt. We were talking as we were preparing for this, meeting. We were talking about some of the other Asians who contribute tremendously to the medical community, who have very little power, and that's the Asian postdocs who really have really very little to say, do a tremendous amount of work, have very little opportunity for advancement, and really never complain. And it's kind of like a hidden model minority that's really slaving away in the background with very little voice, I think. Alex's story, mimics mine, not so much on the overt racism once I've become older, but, so I'm in my early 50s now. And so, I grew up in Buffalo, New York, which is a very blue collar town. And my parents immigrated there in the early 60s. And just to kind of give a sense of what that is like, I always kind of relate that back to World War II ended in the mid 40s. And so if the people who had gone to war were in their 20s at the time, they were in their 40s and their 50s when my parents arrived into Buffalo. And one of the starkest examples of that is that my Korean language is terrible, actually. And it's really because the most important thing for my parents at the time was that I speak English. It wasn't, and that I assimilated into the community. And I remember a time when I was 6 or 7. I was just a little kid, and I was so excited to go to a Buffalo Bills game. And I was walking through the parking lot, and just the overt, like really aggressive racism that I was a little 6-year-old kid like with, you know, and I remember getting home and I was like, I'm never going to a football game again. I'm just never going. And I think it really did shape me in terms of where I thought it would be okay for me to go to school and where it would be okay for me to train and do residencies. And I think, you know, in terms of the as you move up the ranks, you know, if you hang around long enough in congenital heart surgery, you're going to get an opportunity to lead. You're going to get an opportunity to run your own program. There's just, you know, there are just places I just would never consider. I would get opportunities in the South, for instance, or in the Midwest and things like that. And I was just like, that is just not going to happen. I just am not going to even consider that as a opportunity. You know, it's not that California is perfect, as Alex knows, and you know, but you know, even in my children's preschool, or my children's school is a very elite school, and I bring that up just because you would imagine that the parents who are involved are you know, very conscientious about it and kind of really try and instruct their children. In fact, the model of the school is inclusion and all this kind of stuff. But you know, my daughter's 8, and the whole, you know, Asian eye thing came up this year, and I'm like, my wife and I, my wife's Korean, she's a plastic surgeon. You know, it's just, you're like, it's just, we're not going to get away from it.
Well, I want to take that where you from comment, because I had a second part of that, which is, so I'm in a powerful position. You know, I'm a senior surgeon and a department chair. So maybe I'd ask Dr. Berfield, when I hear that, because it's not going to be directed at me, but when I hear it directed to you, what advice would you have for me as a white guy and a bystander of what could I do to be a good ally?
Yeah, I think the bystander and the ally question is a really good one, and definitely one that we've been talking about a lot at the university. I mean, I think that it's as a leader, it's your role, or you know, it's helpful for you to step in when it goes beyond the, like, I'm from Bainbridge. You know, I've had the same questions, like, I grew up in Seattle. You know, to say, you know, like, oh, this is, you know, let's talk about why you're here instead, to redirect the patient. Because I've definitely had the same experience with patients. I think, you know, we literally all have. But I think that as a leader, it's our role to kind of help step in. And like Richard said, we do a lot of deflection and a lot of sweeping under the rug, and trying to kind of move on gracefully. But I think that's probably the best thing to hear from someone that, you know, you look up to as a mentor and as a colleague.
I'll just give a little aside. Is I remember when I was applying for cardiac surgery fellowships, and I was having lunch with a really prominent cardiac surgeon and former AATS president, and I'm sure he was trying to. He meant it as a compliment, but it didn't really kind of. But he was discussing his former Korean and Chinese residents, and he asked me whether or not I was Korean or Chinese, because he felt that the Koreans were more ferocious. I you know, again, I'm sure he was trying to compliment me in some fashion, but nonetheless, it was.
Well, Dr. Kim, I think from a cardiothoracic surgeon, ferocious is maybe one of the biggest compliments.
Right.
You know,
right.
That's what I was thinking. So, you know, Yeah, I was just wondering, we today are 2 years from the incident in Atlanta, where mass shooting resulted in the loss of 8 lives, 6 women of Asian origin, 1 white woman, 1 white man, and 1 Hispanic man was injured. And so it's interesting that this falls just 2 years from that day. But it also brings into play people like Michael. Michael is of Latino background, but he was interested in this because there's a lot of shared experiences and this concept of ally and being diverse and inclusive that transcends the different ethnic groups and different backgrounds, that we all have had these experiences and that sharing them is actually helpful. And I think, Michael was just telling me that it's helpful for him to dig into this history of Asians, even though his background is Latino. So Michael, you want to talk a little bit about that?
Sure. So getting involved in, planning parts of the panel and looking into the history of Asian Americans, I think the preconceived notion is, you categorize all of these groups under one label, but when you really start digging into the data, you realize that each of those groups are marginalized in their own way. Not all of them have the same level of education, access to resources, and I think that reflects on, socioeconomic status and income level as well. I know personally for me, being the first generation, person to go to medical school in my family, I don't really have the knowledge or the mentors or even like family friends, professional connections to, guide me through medical school, and really made it a priority to reach out within Latino Medical Student Association and really find mentors who could guide me, so that one day I will be able to be in that position where I can do the same for others. So I think that it's a great opportunity to hear from the expert panels, your lived experiences, and just hear about how you overcame these challenges and got to where you are today. Because myself and Alex, we're the next generation, and we need to learn from the previous generations to expand and, of course, build a more diverse medical community. I see Alex had his hand raised, so we can.
Thank you. Yeah, I wanted to add onto that, and also respond to Dr. Wood's question earlier. Like, how does someone be an ally? How does someone, in that position? And quite honestly, like, from my own experience, I remember, in December on rotation, I was in clinic. Just to leave some specifics out, but I was asked to leave because the patient told me I was Chinese. I look Chinese, so it was uncomfortable. And I responded in a very professional manner. I said, let me make this clear, like, sir, like, if you're not comfortable with me being here, I will leave. Because that's what we do. We're here to take care of people, and we have to be professional and keep everybody safe. So I left. In that moment, I really just wanted to cry. And I was not okay by any means. I'm a pretty tough guy. I've been like a lifelong athlete. I understand grit, determination, all that, but that broke me. So what I'm trying to say is, I think the most helpful thing that mentors can do, people in higher positions of power, they can acknowledge and believe the hurt. Like, truly, like, not like the least helpful thing. I've had an acquaintance who told me was, are you sure it's that? Are you sure, like, this is A-shape? Maybe it's like, when I got honked at by people and I was pointed at and laughed at in an area where Confederate flags were on cars, they're like, maybe you had toilet paper on your shoe. It's like, are you serious? Don't tell that to me. That hurt. I'm like, don't say that. That's real. That's like twisting the knife in the wound. And building off of what Michael said about these, when you disaggregate data, there are marked differences in Filipino Americans, Korean Americans. You look at clinical differences. In Vietnamese women, we have higher rates of cervical cancer. a lot of differences in this whole model minority myth that Asians are perfect and we're built for this and we're set up to succeed. My dad's a Vietnam War refugee. He came here because he was forced to. I have so many relatives and family friends that were tortured, murdered for, believing in freedom and these things. He came here with not even knowing the language. He put himself through college. How is that being set up for success? Every day I even think about how grateful I am that I'm in the position that I get to do and be a Vietnamese American, because that's not a thing. I am not like a common thing. Like I almost reflect on, I don't belong in America and I don't belong in Vietnam. So for someone to say, oh, but you're Asian, you're smart, you're good at math, you're going to succeed, you're meant to be a doctor. I'm sorry, like that just does not hold true for a lot of people in this Asian American group. With that, I can drive back to moderating.
Well, Alex, first I'd say, I'm sorry. I'm sorry you had that experience of somebody asking you to leave. And I'll tell you what I think the response should be. I pushed for a policy in our health system that is now in place that is actually meant to protect against exactly those incidents, and is to empower our faculty and staff that we cannot be bullied by patients in ways that are biased incidents. And if I was in the room with you, it would have been, Dr. Nguyen is going to stay. There's not a reason to be concerned about him. And if you are, you should seek another place for your health care. So I think that a situation like you portrayed, I think it's relatively easy to figure out what the appropriate ally response would be from my perspective.
But it's good to have this discussion, because I can honestly say that if I were there at that time, I would be so shocked that I wouldn't have a good response. So I think being able to pull this out and have it loaded up in my mind it's so helpful. So I really appreciate that. I do feel I can say something, because sometimes you're just powerless in the moment because you're so shocked.
It's surprising, but those things that are surprising, having a discussion like this helps you be prepared. So you've got, okay, I've got my answer for when this happens, because you've had a chance to think through it once.
Yeah, I agree. I had said before that, as nationally, we kind of, the whole Asian hate movement kind of had built up. It's so interesting that when just a few short years ago, I really had believed, when Obama, was president, I really had believed for a moment. I said, something, it is so much better now than when I grew up. I really had believed that. And then with the rise of Donald Trump and many of the kind of goings on that come along with that, I remember being really taken aback and really shocked almost. I had thought that it was different, and I realized actually that it wasn't different. It was just kind of swept under the rug, so to speak, in many circumstances. But what I do think has changed is that I think, as Dr. Wood has said, is that I think the hospital administration, for instance, or the medical school administration would have very, very little tolerance for incidents with patients. And I think you would stand on very strong footing to do as Dr. Wood had suggested, and you would be well supported in asking this patient to seek another place for their medical care.
I've only had to do that a handful of times, and no one's ever left. They got their act together and behaved politely and professionally and respectfully.
I wanted to get back to Dr. Berfield's comment about the intersection of being a woman in CT surgery and also of being Asian. I think that there are, again, stereotypes that fit women and fit Asians, and then Asian women is a totally different setting, as we both grew up in cultures where, in households where there is a certain role for women. But that being said, there is data to back this. And we recently, through the workforces of diversity, equity, and inclusion, have looked at salaries. And we know that among Asians that we have compared to our white colleagues, lower salary. And the intersection of both women and Asian is an even lower salary. But the good news is that at the level of the chief, it tends to equalize. That's not the way it is for all races, but that's what we know now, is that it seems to be better when you're in the position of power, like we discussed earlier. But when you are an assistant, an associate professor, and even professor, there is disparity in salary. And so it's more than just the perception and more than just feelings of inclusion. There's hard data that the value in terms of compensation is different.
Yeah, my wife is a plastic surgeon, and it is a very real problem. I think the intersection with being female is a really important thing to bring up. Many times, it happens all the time. Like loud, aggressive male surgeons, they just get away with it just because it's too much trouble to try and rein it in. And you'll find my wife, for instance, she gets bumped all the time for these older, despite the fact that she's booked out for a year. I mean, and she is one of the single busiest plastic surgeons in a big hospital system. It's just to be fair, actually, it's many times the people who are the biggest problem are female nurses, in my opinion, who you think would really want to support other female surgeons. I find that not to be the case.
Yeah, I have to say I've been fortunate, unfortunate, depending on the way you look at it, to be a federal employee. So I have not had the issue, but there are different issues being a federally employed in terms of salary. And I think, we got a comment from to the panelists about, also just in Asian culture, it says, it's frowned upon for self-promotion. So you tend to be deferential and you tend to let your work speak for itself and hope that someone else notices that you're doing a good job and you're putting, your time and effort into things. Because I taught all along, like, you're supposed to be humble and you're supposed to kind of downplay your contributions, right? Like, if people should notice on their own, which doesn't always happen. So I think that's also where, our allies come in terms of recognition and helping to kind of call out the contributions of their colleagues, their Asian colleagues, and especially Asian women.
I think that's incredibly true. Actually, during the as you're going up the ranks from assistant to associate to full professor, it is also prized within the cardiothoracic community. Everybody particularly loves the guys who and women who just put their head down and work hard. And so as we've all gone through these residencies and through the system, it's like those characteristics are so prized, right? And you're going to do your best. And so when when it melds together with a cultural, the cultural belief that you'll be recognized if you work hard enough, and then with the cardiothoracic belief that I'm not gonna say anything. I'm just gonna work harder. If I work harder, they'll notice me. And so you get the double duty. And then hence the expression is the longer you stay, that's what happens. Yeah.
Okay, I think we can have our poll results, if you could pop those up. And I don't know, are Asian minority in cardiothoracic surgery? I don't know. Now that's a really interesting answer, because as Alex and Michael noted, that we have an overrepresentation of not only physicians, but also surgeons, meaning that there are more thoracic surgeons by proportion who are Asian than our population in the United States. So, but Dr. Berfield, tell me a little bit more about, your impression of, are we a minority group? Are we underrepresented in medicine? What do you think?
Well, and I've never been good about keeping track of the percentages and numbers and things. But I mean, I think we are, right? If you look at the aggregate, the number looks pretty good. But when you really look at it kind of individually, we still are. And I think that is the difficulty with the kind of model minority sort of implication, right? Of people just don't realize it. They think that we're Asians are everywhere. we're all over medicine, right? Whether it's nursing or physicians. But really, I think, we don't make up the majority, and we're even close to it.
Hey, Alice, can you just comment on what it is these days for Asians to get into medical school?
Just like, I guess, my experience, or like just in general. Yeah, honestly, I actually think it's like pretty hard to get in. I don't know why. I think maybe actually speaking on in undergrad, how about getting into undergrad? I actually did. Even with really good GPA, had like a 4.0, pretty okay test scores, and the UC system like really destroyed me. Like I got in 3 out of 12 schools, and a lot of it was like, oh, perhaps there were just so many Asian applicants in California. But to answer your question briefly, I guess I think it could be harder on average. I'm not sure.
So another comment brought up, and I take some offense to the comment, but there's another comment about that Asians often, besides the earlier comment that was very useful about not being self-promoting, also are young looking, and therefore not like me. And that also might be a barrier to having, at least being perceived as a senior status. So, Dr. Erkmen, you're a professor of surgery. Do people think you're too young to be a professor of surgery?
I think that it does play in when you're looking at promotions. I think with patients, they're very open to having people help them in any way, shape, or form. But I think actually among colleagues, it's been more of a challenge, that getting status is more than just what you do. Nobody can see your resume when you walk through the door. And it does imply to colleagues, maybe even in other professions, that you have experience, that I have experience, that I have input into this. And I would say that it does play a part in whether I want to switch jobs or, look for a job elsewhere, because it's taken so long to get this foothold where people don't say, oh, you're young, or, oh, you look like you just graduated from medical school. I think that among my own colleagues, that it plays a role. Yeah.
I've definitely seen it with patients as well. I think that I have gotten a lot more comments about how young and pretty or young and exotic I look from at least my veteran population, mostly male veterans, and have had to try to dodge / maybe sometimes answer the "how old are you" kind of questions. And it's like I'm 6 years out of practice or out of I have 6 years in practice, and I've trained at the university and trying to kind of explain away those things. And but I think that it's kind of continues to be a pervasive thing as well.
Well, I'd say, Dr. Berfield, no one has ever made those comments to me. That I'm young, pretty, or exotic.
Exotic.
I'm kind of disappointed. I do feel that now I'm going to perceive that as a microaggression against me, that I don't get any of those comments. So I'm looking at the comment about the fact that numerically Asians are overrepresented in medicine and in cardiothoracic surgery, but that may not represent how it feels to still feel like a minority in terms of power or advancement, and some of the points that Dr. Erkmen was making earlier. Dr. Erkmen, what could we see, or how could we know we're making progress? If it's not in the numbers, if it's not the percentages, how could we feel like we are making progress in AAPI individuals not feeling like a minority in cardiothoracic surgery?
I think part of what we were discussing is just creating a global environment where we value people being different. And, you think about when you're building a basketball team, you don't want everybody to be a point guard. You don't want to recruit, 12 point guards. You need to have people with lots of different skills and backgrounds and experiences, when we're even talking about patients, and having someone on the team who speaks different languages, and maybe that's their culture. They'll understand how to communicate with people. So it may not be targeted towards, okay, how do we make the environment inclusive for Asian and Pacific Islanders, but how do we make it just so that everybody feels valued for being different, not valued for being, the same, and having these strict criteria of success, and that we start to broaden our concept of success away from test scores or from the number of publications, and look at what different experience do you bring to the team. So I would say we really have to look at a general policy where we value this diversity, and we are not afraid to accept people for the different skill sets that they bring.
Yeah, I think that's a great point. And one of the questions I guess I'd have is how's the right way to characterize AAPI individuals? Do you put them in a BIPOC category? Are you in a marginalized category, like we often use as labels for underrepresented minorities? Which of those types of labels are useful and which are offensive?
you know, it's a great question, because, you know, I think part of the difficulty in answering that question is that everybody, the one thing about Asian populations are they're so different, and the experience is very unique, you know, culturally and socioeconomically, and, you know, the experience of people who were raised in America who versus who came to America. I mean, it's you know, I think it's important in that everybody feels, I think the common feeling is that there is an undercurrent of I don't know if it's appreciation or an undercurrent of feeling different, and it's not feeling different in a good way. It's feeling different in a isolating or it's not always offensive, but it definitely is segregating. So, you know, although everybody has a different experience that they bring to the table, I think there's a communal underlying current of being somewhat different. You know, it's very interesting is in a couple of weeks, I'm you know, we're taking our kids who are 8 and 10 to Korea for the first time. And although Korea, I'm not Korean because I was born and raised in America, but for someone who's been raised in America and you know, been in communities like Buffalo, or even, you know, I went to East Coast boarding school, which is like a crazy institution, you know, like for someone to be in. When you go to Korea and everybody around you is Korean, it is a totally different experience. It is very hard to explain that, and it's very hard. And I want my kids to understand what that feels like. And, you know, I was born and raised in America, but there is definitely a part of me that is like, it's not American, you know.
And I think, you know, it's hard to say how are we going to measure this. Alex and I had talked earlier that there are some subgroups within the Asian Pacific Islander that are considered underrepresented, and you know, that changes, and how do you keep track of that, and how do you keep track of the terminology? It's very difficult and challenging, and it's not like we're a monolith and we all talk about things in the same way and agree to one term. But I think, you know, measuring our success is measuring the success of, you know, how diverse of a profession are we? And it's a very broad stroke. You know, what is the demographic makeup of our profession, both by gender and also by race? But we have to keep track of that. And even though it's a broad stroke, we need to do that because cardiothoracic surgery is, you know, lacks diversity. And so it's hard to say how are we going to measure it and how we're going to move forward, but at least we know we have to move forward from where we are right now. So I think our time is running short, and I really appreciate our panelists for taking the time to put together this work and their thoughts. And I appreciate the STS and the Workforce of Diversity, Equity, and Inclusion for creating this forum that can be shared. And thank you tonight for tuning in. I appreciate it. Have a good night, everyone.
Thank you.
Thank you, Doctors Erkmen and Wood, and thank you to all our panelists today for such an incredible conversation and insight into Asian Pacific and Islander experiences. We will continue these discussions on April 13th with the shared commonalities and differences among underrepresented surgeons. Same Surgeon, Different Light is a program from the Society designed to demystify cardiothoracic surgery, revealing the men and women behind their surgical masks. Visit sts.org/podcast for season 3. Thank you so much for participating, and we hope you join us on April 13th to further this discussion. Thank you so much. Have a great night.